So let me just tell you a little bit about our LGS journey. I have a 27-year-old named Savannah who has LGS. And she was born and was typically developing, no issues. And she was fine till about the age of 2.5 when she had her first seizure. It was out of the blue, nothing that we saw that precipitated it. And no testing, the testing that we had done didn't reveal any changes in her. She had no structural malformations. All of her blood labs came back. The EEG was normal. And we thought we dodged a bullet. And she had a couple of more. They were all tonic-clonic seizures in the beginning. We didn't know that. We didn't even know what a seizure was when she had one. And then she went 6 months without having any seizures at all. And at the age of 3, the seizures came back, and they came back with a vengeance. She started having them every day. She started having multiple seizure types. And for the next 16 years, we never did get them under control. She was not diagnosed with LGS until the age of 5 years old, even though the seizures came back at 3. And this was because 20 plus years ago, video EEG over 3 to 5 days in the hospital was not standard. But it's also because, and I didn't know this back then, it's because LGS evolves. And we're going to talk about some of the research around that. So once she had LGS, it started to group her into a category of children that were not going to grow normally. Most people with LGS continue to have seizures and have trouble learning and ultimately have developmental delay and intellectual disability. For Savannah's story, she seized every day, more than 40,000 seizures until she was 18 years old. And when she was 18, we did genetic testing on her. And this was part of my research as a PhD and a postdoc, where we found that she has a calcium channel overactivation disorder. We actually found a medicine that really helped her. It reduced her seizures by 95%. It stopped her status epilepticus by 99%. And she really began to grow and develop again. And now at 27, it's not perfect. She still is intellectually disabled, but she's doing very well. So she has a developmental epileptic encephalopathy. She has LGS. She has a calcium channel overactivation disorder. She has all of those things. But I love the LGS community because this is where I come to get real life tips on how to live with this disorder. When we first came into the space, this is what we knew about LGS. There was this concept of a clinical triad where you had more than one type of seizure, moderate to severe cognitive impairment, and slow spike and wave on the EEG. And then there was this umbrella of causes, all of these things that could cause LGS, genetic malformations, birth injury, all these things that we've learned about. The problem with this characterization of LGS and the definition is that it doesn't capture the journey of LGS. And I've met doctors today, adult neurologists, that are like, I don't have any LGS patients because that's a pediatric condition. And it's not like our kids just pop up out of the snow like daisies one day. They evolve to LGS. And then when they get diagnosed at LGS, which most often happens between 3 and 5 years of age, they further evolve and change. And so we really need to think about the definition of LGS as it goes across the journey. And one way that we've tried to capture that here at the LGS Foundation is this evolution of LGS over time. My slides are advancing on their own for some weird reason. So over here, you have LGS on the right, and this is the clinical triad we just talked about, more than one type of seizure, EEG, and then cognitive impairment. We're going to talk more about this. And it doesn't really matter, how you got to this point where you have LGS. The outcome is pretty much the same. Most have seizures into adulthood. Almost all of them will have tonic seizures associated with sleep. More than 90% will have cognitive impairment, and there's an increased risk of death. But before, the kids have LGS, they have treatment-resistant epilepsy. And before that, they have epilepsy, which means 2 or more unprovoked seizures. And before that, they'll have their first seizure. And before that, they'll have a cause. So we need to rethink how we define LGS. And there's a lot of active research work going on to really look closely at patients to define what LGS looks like. So how do we define it today? The definition has changed quite a bit over the last 50 or so years, but today it's multiple seizure types. Tonic seizures have to be present, but you could have any other seizure type. Non-convulsive status and status epilepticus are often present. The ILAE says you need to have both slow spiking wave and this GPFA that Dr. Worrell talked about, this paroxysmal fast activity or generalized paroxysmal fast activity, which basically means that you're having a tonic seizure. That is the signature of a tonic seizure, and you can see it over here on the right, GPFA. Slow spike and wave is not associated with a seizure. It's an abnormal pattern that you see in LGS patients. But there's also this age of onset of seizures under age 7. So it's not really a triad. It's a quadriad, right? Or it's more than one feature. Most patients are diagnosed with LGS between the ages of 3 and 5, but some can be diagnosed younger and some older. And then some just don't get diagnosed for a long time because of the way that they're treated and they're not tested properly, and they find out when they're older. And then there's cognitive impairment. And this is here listed in blue because in about a third of LGS patients, developmental delay is not present at the time of diagnosis. So it is not diagnostic criteria, but more than 90%, it's actually almost 99%, will have cognitive impairment within 1 to 5 years of the diagnosis of LGS. So it's not always present, but you often hear that it's diagnostic criteria, but it's not, but it will be present at a certain point. And it is really hard to define this because LGS is a syndrome. It is a collection of symptoms. And those symptoms are based on the EEG. And if you're just looking at these squiggly lines over here on the right that are taken from patients, it's really hard to capture minute differences in the EEG from some of the other epilepsy syndromes that exist out there. So here's a list of some of the syndromes that exist out there. And LGS, you can see here, is in the gray. And they all have age of onset of seizures at different times. You can also have seizure syndromes that evolve. As Dr. Worrell talked about, Ohtahara syndrome and West syndrome often start out as Ohtahara and West and then become Lennox-Gastaut syndrome later. And it's so important for us to not only figure out what the syndrome is, because that impacts treatment and research, but also what the cause is. And we're going to talk a little bit more about that. So there's a lot of work that's gone on that LGS Foundation has been a part of over the last few years, where we're really looking at this evolution instead of just describing LGS as this static thing, with an umbrella and a triad. It really is this evolution, and we want to understand that so that we can treat those that have it properly, but also try to prevent it in those that are beginning to develop it. So here's the criteria now, and a lot of work, like I've said, has gone into this, so we know what we're studying. Now let's talk about the research that's going on in treatments. And I think Dr. Perry did a great job talking about all the treatments that are forthcoming. And we talk about how we treat LGS. Let's be real here. We treat the seizures, and that's about it. There are so many other features of LGS that we don't even look at. So that is where most of the research is going on. And I think as a foundation, we can actually shift that. We do want to stop the seizures. We absolutely do. I'm having trouble here. We do absolutely want to do that, but we also want to look at the other features of LGS. So just to review what Dr. Perry talked about, we've got multiple drugs that are FDA approved for LGS. Then we have multiple drugs that are not FDA approved, but show utility in LGS. And then we have more drugs in the orange there that are commonly used in LGS, but there's not really any evidence. And not just that, but there are diets. There's a new diet therapy coming out. We've studied ketogenic diet. We've studied low glycemic index diet. We've just studied Atkins diet. There's a trial going on right now for a special diet low in glutamate. And so if you want to know more about that, please email me and I can tell you more about that. But there's a bunch of diets that all show utility and work in some patients with LGS. There's also surgery. There's devices. Deep brain stimulation is emerging. Responsive neurostimulation, RNS, is emerging. That's another one that is different from DBS. The thing is, though, is all of these treatments are considered palliative, meaning that they're meant to reduce seizures, but none of them are a cure. And most of them don't cause a huge reduction in seizures. Like when we experienced a 95% reduction in seizures, that was a huge change in our quality of life. But if my kid's having 200 seizures a day on average, and you reduce that to 100 or 150, I'm not sure that my life got any better or my daughter's life got any better. And so we need to do better with these. But these aren't the only drugs and treatments that our kids go on. There are more than 40 epilepsy approved drugs that are out there. And we as patients get stuck in what I call the proposed management loop of seizures. This has come from a number of publications at this point, but we get our diagnosis of LGS and we get put on a medicine, our loved one, and the family is usually responsible for managing that. But the seizures are still refractory. So we get stuck in this loop of just trying seizure after seizure med after seizure med after seizure med. And then maybe we enroll in a study to try a new medicine because maybe we've tried everything, or maybe we don't want to try those and we want to go to something new. And then a few of us might get brought over to a surgical evaluation For those that qualify for resective surgery, where they remove the part of the brain where the seizures are coming from, their LGS can go away. They can become seizure free and their EEG gets better, and then they can go on to live a normal life, but it's less than 5% of all LGS cases. And then there's palliative surgery, where we're not going to stop your seizures, but this might help. And that's where they do the corpus callosotomy or the VNS. And we just get stuck in this loop. And so many of us in the LGS space have tried so many therapies. For my daughter, she had tried and failed 26 different things, including alternative therapies, diets, devices, drugs, surgeries. And it was number 27, a medicine number 27 that helped us. And so I think that tells us that we should never give up. But I think that, by the time drug number 27 rolled around, I wasn't feeling very optimistic anymore. I was so happy to be wrong about that. So there's a lot of room for us to do better, because if you remember, if you go back, no matter what your cause of LGS is, cause of your seizures, the outcome is pretty much the same: continued seizures, progressive intellectual disability, risk of premature mortality. And we're not making a radical dent in those numbers. And just to highlight, I know Dr. Perry talked about this, but the side effects of all of the meds that our kids are really compounding. And we get to a place as caregivers and people that are living with LGS where we don't know what's the seizures and what's the medicines anymore. And I know the seizures are worse, because my daughter's been on medicine at times where I didn't change the medicine, but the seizures started and they ramped up and she almost died. And so I know the seizures are worse, but I know the medicines aren't helping. And most patients with LGS are on 3 to 4 medicines. They've tried more than 14 of them. And I'm going to get to that research that we've done to look at that. But we have a lot of work to do. And so when you go back to this, we know what we're treating now. We have a good definition of LGS, and it's further being perfected. But there's so much work that we need to do at the LGS Foundation to really think about what are the best treatments. I am so thrilled that there are companies that are making drugs to target seizures in LGS, because if they weren't doing that, they would basically just be saying, sorry, I'm really sorry for your kids, have a nice life, there's nothing we could do. So I'm so happy for that. But I think we as the foundation want to tell them how they can do better. And one of the ways that we're working to do that is to begin and continue and amplify bringing the patient and family voice into the arena. And you and I and those of us that are living with LGS are the experts in this disease. And so largely drug development and research have gone on without our voice, and that is now going to change. It has been changing over the last few years, but our voice is getting louder and stronger. And the more of you that step up to join your voice with ours, the more of an impact we can have. So I told you I was going to talk about this a little bit earlier. This is something we're really excited about. We were granted the ability to host a patient-focused drug development meeting. We called it our DELVE meeting, DEE and LGS Voices of Experience. This was held last November, where we went in front of the FDA and we presented what information on what LGS is, very much like you heard this morning from Dr. Wuerl and Dr. Perry. And then we had a number of caregivers who all got up and read their testimonies about what it was like to live with LGS across the years. And that was the beginning of a conversation with the FDA and with drug makers and with researchers and doctors about how the patient voice can be integrated. As part of our PhD meeting, we surveyed the community. We came out to all of you in the community in 2018 before we had this meeting, and we got responses from over 417 different countries that responded to the survey. And we learned things like, even though Dr. Wuerl said that we don't know the cause in about 20 to 30% of LGS cases, when we asked you, 64% of you said you did not know the cause of your LGS. So the community is not doing a great job at letting us know. They may know the cause, but they're not telling us. And we need to understand that. And in addition, they're not telling us that LGS is this evolution. So that was really clear that we need to really push finding the causes as we can. In addition, we saw that seizure onset was coming. We have a first seizure type was most often infantile spasms and tonic-clonics, and the age of the first seizure was most commonly seen in the first year of life. And this is backed up by some research that's been done by clinicians prospectively in the lab. And so this is really exciting to think about as we start to identify these early seizures and try to get to the root of LGS and stop it before it has a chance to really spread, to really metastasize. We learned from this survey that LGS kids are having a lot of seizures. daily tonic-clonics in 42%, daily atypical absence in 41%, daily myoclonics, daily atonic. And for the most part, the majority of the population was having seizures daily, weekly, or monthly. Very few were not having seizures at all. In addition, seizures were coming in clusters or were coming in status epilepticus, and there were recurrent uses of rescue medicines, also daily, weekly, and monthly. At my daughter's worst, she was getting Diastat, rectal diazepam 2 to 4 times a week to stop non-convulsive status. And while we were really lucky to have that, and most of the time it worked and we didn't have to go to the emergency room to get more meds and possibly be put into a medically induced coma to stop seizures, I still don't think you should be using rescue meds 2 to 4 times a week. There's got to be a better way to help our kids so that they're not going into status so often every week. We also learned that seizure injuries were incredibly prevalent in our population. Again, daily, weekly, monthly, or at least a few times a year in more than half of our population. And then, of course, and we all know this, there are so many symptoms other than seizures. There's the developmental delay and the communication issues that come with that. There's psychiatric issues, aggression, irritability, impulsiveness. There's sleep disorders, whether it's nocturnal seizures or having trouble falling asleep, staying asleep. There's behaviors, autistic features. There's all sort of mobility issues and feeding issues. So LGS is so much more than that, than just the seizures. And if we're going to be making therapies and against the seizures, we really want to make sure that those therapies aren't making communication worse or sleep worse or behaviors worse. And so we need to begin to be thinking about those. So here's just some information that most of us have tried drugs. Again, most of us are on more than 3. The top drugs that were reported by all of you were clobazam, valproate, rufinamide, levetiracetam, and cannabidiol. But then we went in and we asked you the questions that only you can answer, which was of all of these things, 97% of patients in the survey, that it was caregivers. There was one person with LGS that filled out the survey. Everybody else was a loved one or a caregiver. 97% said they were still having seizures, 87% sleep disturbances, 81% head and face injuries. There was severe developmental delay. We asked you how you would prioritize. If you look at that whole list on the left there, wheelchair use, can't read, can't write, nonverbal. We asked you, what would you prioritize? And that is something that only we can do as a community. And what you said was the first thing was seizures and safety. And we hear you loud and clear. I mean, it's not the only thing we're dealing with, but we are dealing with a lot of seizures. The developmental delay, especially communication. We have so many nonverbal kids in our community that just because they're nonverbal doesn't mean that they don't communicate, but we can't always tell when they're in pain. We can't always tell when they're hungry. And so how can we really increase communication? And even for the kids who are verbal, how do we help them to express themselves? And the behavior was the third one that came up, especially aggression. And then, of course, these other here, mobility and physical care, sleep, cost and access, and social isolation. And we have a lot of issues in LGS, but how do we really focus as a group on the things that matter most to those of us that are here? And we just tackle these one at a time. We also did a lot of work this past year with Dr. Ann Berg, who's been a regular at our conferences in the past, really looking at what this idea of seizure burden means. Seizure burden is so much more than the number of seizures, but that's often all we ever count when we're doing research and when we're doing clinical trials. But the seizure, is represented here by the red spike on the graph, is just one piece. And of course, it's an emergency. Is it going to be a crisis? Do we have to go to the ER, rescue meds? Are we going to be admitted? Is she going to be put in a coma? Is she going to have to go to the pediatric ICU? Is she going to die, right? That's the seizure emergency that you're dealing with right in that time frame when the seizure happens. But then there's this whole aftermath, right? So if you're admitted, then you go that whole route to the hospital. But if you're not admitted, are they injured? Did they wet themselves? Did they defecate themselves? You're looking around, who witnesses? Are they worried? Do you need to, do some damage control there? Did you miss work because of a seizure? What plans were interrupted? So that's the whole aftermath. But then there's this period of this constant anxiety that we have. It's like, first of all, when's the next seizure going to happen? And how can we be prepared? You need to wear your helmet. You need to sit down. You need to go to, and to a place that you're going to be safe. We are on guard 24/7, 52 with these kids. And then we have all this other life stuff that we're supposed to do, like go to work and cook and clean and go to the doctors and haggle with insurance. So seizure burden is so much more than just seizure number. It's also all of the stuff that goes with this, as well as seizure length and intensity. And so we worked with Dr. Berg with a number of different severe developmental epileptic encephalopathy groups. You've got this seizure that you can have a severity to it, a frequency, which is the number, but the unpredictability of it too. When my daughter would seize, one day she'd have 5 seizures and the next day she'd have 500 seizures. And you just never knew you're going to get that unpredictability. And then that leads to these external issues where we can't make plans, and it impacts our quality of life. And then that also impacts our chronic traumatic stress disorder issues of feeling constantly overloaded. And so, you can tell I'm like getting more and more worked up thinking about all of these issues that we just don't tackle, but we've defined them now and we've prioritized them as a community. And it's now time to take our voice back to this pipeline where we have researchers who are actively studying the LGS population, actively making medicines, actively making treatments and new surgeries. And so we need to bring them our voice. So coming this November, I just looked at the final timeline and we're going to be able to bring this out, but bringing our voice of experience report out to the masses. And we're going to need all of you to help us, but we really want to use this report to communicate what burdens us. And only we can speak to the burden of disease as caregivers and patients, and only we can speak to what would be an added value. So watch for that in November. I'm really excited about it. And thank you to all of you in the community who made this possible. So I'm a little emotional today. Sorry, it happens sometimes, but it was really lonely growing up without anybody when we were living with LGS. So I just love this community. So let's talk more about research as we move forward. We've brought the most important piece in, which is our voice. And now research is not going to happen without our voice. But what about the causes? So we've talked about this pipeline of you've got, the first seizure, epilepsy, treatment-resistant epilepsy, then LGS, and then making medicines and trying treatments. But there's a whole section missing, and that is causes. So all the way over there on the left, or etiologies. And I think that Dr. Wuerl and Dr. Perry gave excellent examples of how we are identifying the root causes of the seizures that can lead to LGS and how we might be able to target those. And so progress has been made. We used to, when I first came into this space, we talked about LGS as structural and unknown. And we talked about LGS as cryptogenic, idiopathic, and I can't even remember the other name, cryptogenic, idiopathic, which is good because I forgot the names of these things, but it'll come to me. We don't refer to it that anymore. We start to talk about it based on LGS as this network disorder of brain waves that has these symptoms, and then there are all of these causes which are listed here. And so I'm not going to go into these other than just to say these slides will be made available if you want to look at them. Here is a list of many of the causes for LGS. Just a small number of the genes are listed over there on the right side. This is just a tiny number of more than 100 genes that can predispose to LGS. Genes, genomic regions where there's a mutation or a chromosomal abnormality that can predispose a child to developing LGS. Probably the most notorious example is tuberous sclerosis complex, where about 80% of babies born with a mutation in the TSC1 or TSC2 gene will develop infantile spasms. And then another 40 to 50% of those will go on to develop LGS. And that is probably the most well-characterized example. But we know that if we can find the gene and the cause, we can begin to implement precision therapies now. And so here's a list of precision therapies that exist for a number of the genes. And sometimes it's go on this medicine, and sometimes it's do not go on this medicine. And sometimes it's watch for gait disturbances or tumors or heart defects, and we're just beginning to really break open this area. So it's so important to know both that you have LGS, but also your etiology. And I know for those of you that are in the community who are living with acquired forms of LGS, which is about half of our community. There is hope for us too. 20 years ago, we started studying brain cooling when I first came into the epilepsy space, and now there is full body cooling that is used on infants who have hypoxic ischemia or a lack of oxygen at birth. And that is leading to a decrease in the number of babies that are developing seizures, which means that'll be less that develop LGS. And there's some really exciting work going on what happens after there's a brain injury in a baby. Over here on the right side of the screen, you can see there's a brain injury, but then there's all of these things like mitochondrial dysfunction at the cellular level and cells dying, apoptosis, and then there's an inflammation that happens. So is there a medicine targeted to those effects that happen after the baby has a birth injury, but before they start having seizures? And so it's a really exciting time to be thinking about how we might intervene. And there's a ton of research going on in this area. And I can't wait to give you a talk about all of that's going on in that area next year. So there is a lot of work going on. We have a lot to do, but right now we're still trying to make sure families understand the cause of their LGS, of their seizures that led to their LGS. So if you need help finding that and understanding that, please do not hesitate to contact us. We would love to see that number go from 60% who don't know down to the 25% or so that even science doesn't know for them, and then down to 0 one day. So then there's this whole concept of this idea of the stuff in the middle. How do seizures evolve into LGS? So this whole section here where you go from your cause to your first seizure, then your intractable seizures to your LGS. And there's this whole concept of an epileptic encephalopathy that I want to talk about here. But first, let me just show you what we know about that. So this work has really been pioneered by Anne Berg, who is just one of the stellar pioneering researchers in LGS, like Dr. Worrell and Dr. Perry. And here on the left, it's a little bit of a confusing graph, but each of those lines represents one patient who has LGS, and they followed a total of 22 of them. So this top line represents patient number 1 who had LGS, and you can see they started out with having about 1 to 10 seizures in their first year. So they were diagnosed with LGS here at the pink point. And in their first year, they have a little green line up there at the top. In year 1, they had about 11 to 50 seizures. And then in year 2, that went way, way up. And then by year 5, they had somehow managed to get 5 years after the diagnosis. So remember, they're usually getting diagnosed about 3 to 5. Then their seizures went away and they were seizure free. So that top person was seizure free. But let's look at the next person. The next person, started having a lot of seizures, had more seizures, and then was lost to follow up. We don't know what happened to them. But you can see there were patterns. Some patients started with a high number of seizures and had more, and other patients started with a low number of seizures and developed more, and some patients were seizure-free. So what does that look like? Well, this was the data that came out of following these 22 patients for up to the time they were about 20 years old. And this is a really expensive, difficult to study to do. I hope we can do this on more patients now that medical data is available. But they followed these patients from the time of diagnosis, and 3 out of 22 so 12% were 5 years seizure-free at the last contact. And 5 years seizure-free is a magic number where you're considered to be really resistant to developing seizures again. And then, of course, we saw all these patterns of fits and starts with seizures. And I think that there's some really interesting data there we can look at. The problem is even if their seizures start, 100% were intellectually disabled, and over 90% were at the most severe scales, moderate, severe to profound intellectual disability. So even though we were able to stop the seizures in some of them, we weren't able to always correct the intellectual disabilities. We have a lot of work to do. Part of the same study, so again, looking at those 22 patients, if you look down here at the bottom circles, this is the patients that were initially diagnosed with whatever they were initially diagnosed as. So initially there were 4 that were diagnosed with LGS. And there were 4 that were diagnosed with something else. There were 6 that were UND, undiagnosed. 23 had West syndrome. But then if you follow the line from those up to the end of the follow-up, you can see that so many more ended up with LGS. They didn't start with LGS diagnosis and they ended with it. And this was just over a 2-year period that they were followed. So this was only within the 2-year time frame. So what this data showed us is that from the time that they initially get diagnosed from their seizures, is probably not the day they had their first seizure, but from the time that they diagnosed to their first seizures, only a few of them have LGS right at that moment. And within 2 years, a bunch of the West syndrome ones and a bunch of the focal epilepsy and the generalized became LGS. So LGS happens while we're sitting there watching these kids continue to have seizures. And that means that we can intervene. And we know who's most at risk from these following these same patients is that if you looked at the ones who had the age of onset for their initial seizures who developed LGS, you could see that those that developed LGS in the first, or that developed seizures in the first year of life were more likely to develop LGS. And so we can begin to think about concentrating our efforts in those first year of life seizures and really trying to target those because they're most at risk. And we can also think about in the future, thinking about how we might identify those at-risk children so we can intervene somehow. So we know LGS evolves and we know that we can potentially intervene. And we know from Dr. Wuerl's work that patients who can get surgery, that we can reverse their slow spike and wave or stop it completely. And we know that patients have become seizure free and you can write their EEG so we can intervene. And so this concept of this developmental and epileptic encephalopathy really is that you've got the seizures that lead to this abnormal brain activity, which leads to the impact on development. And that's what we want to try to change. So let me show it to you another way. You have the seizures, which then lead to the slow spike and wave. This is the culprit, which then leads to the developmental slowing and regression. And we need to be treating the slow spike and wave. And we need to be understanding the slow spike and wave. And we don't treat that. We treat the seizures. And so I think that's the next frontier for LGS research. And LGS Foundation has already funded some amazing research in this area. Dr. Wuerl already talked about the default mode network and the attention network and how one's supposed to be on at a time, but they're both on at the same time in LGS. And then these correlate with the slow spike and wave and the PFA, the GPFA of LGS. So we've already begun to understand what networks are involved. And we know from work that we funded at the foundation that deep brain stimulation can act on these networks. This is one of the first treatments that we have that acts on the whole network, as opposed to on one ion channel or on the symptom of seizures. And so this is an exciting time for us to be getting in where the technology and the ability to study patients and collect patient data and the technological age and imaging age are going to allow us to really understand LGS so we could try to get to a point where we get the right drug to the right patient at the right time. And maybe it's not a drug, maybe it's a device, maybe it's a diet, maybe it's a surgery. We don't know, but we're starting to understand that instead of just drug after drug after drug, which was our journey. So in the next few minutes, let me just say where we go from here. Where we go from here is we start interjecting our voices at all of these areas. We need to learn our etiology if we don't know it. We need to start funding research across this evolution, and we need to interject our voice for those that have LGS today on how we can develop better therapies. We're going to start by doing that with the Voice of the Patient report, which I talked about, and we need you to help us spread the word. We also fund amazing research here at the LGS Foundation, and so much of what I talked about today was based on all of the research that's been done in LGS, but so much of it has come from our amazing grantees, and we're going to be highlighting them coming this December as part of a bigger picture as we move into 2020 for our research-focused year. We all need to become more educated. We have these webinar series. You're here at this conference, but you guys heard from Dr. Wuerl and Dr. Perry. So much of that information resides only in the epilepsy neurology experts. Those two people are epileptologists. We need to make sure that that information gets to neurologists and it gets to pediatricians, and we ourselves need to be educated. And there's so much work to do, and we can start with ourselves. Part of getting educated is going over to our exhibit hall. Each of the sponsors here today and our presenters are all here, and you can learn about the new medicines that are coming, but we also have Danny Did here that can talk to you more about SUDEP. I know all of us are terrified of SUDEP for our kids. So Danny Did is here, and Vitae is here to talk about how you could get genetic testing. Dr. Perry will be here. You can talk to him. Seizure Tracker is here to help you learn how you can talk more about tracking your seizures and counting them with an online diary. There's safety beds here from Courtney Beds, Canine Assistance, Service Dogs, Rare Patient Voice, Hanatopia. Please go over and talk to them in our exhibit hall and learn as much as you can. And then on my last slide, I just want to say that we are so excited to announce that coming in 2021, we're going to be really focusing on research. And so much of that has been made possible by the Chan Zuckerberg Initiative, where we got a grant at the end of last year from them to grow our research network. And it is going to take all of us to fund more research and to grow our network and to become educated. But the future is incredibly bright for LGS research. And I'm just so excited to give you this talk. And I know we just have a few minutes left for questions. I went a bit over, but I hope you guys are excited about this as I am, because I just geek out about this stuff. And we have come so far in the 25 years since Savannah was diagnosed. And we have so far to go, but it is so much better now. So thank you guys, and I'll take your questions. And sorry, I'm a crier sometimes. Thank you.